Hi, my name is Karen Morrow, and today I'd like to talk to you about fall safety. Just an introduction about falls. Falls is the #1 adverse event in hospitals, not just in the United States, but also around the world. It is because it increases hospital cost, and then it's an indicator of quality of care. The prevention of falls will decrease injuries, sentinel events, and disabilities that patients face once they do have a fall. And as far as assessing patients, I want you to see this video because it's a good indicator of what people are doing around the world in order to try to cope with the falls epidemic.
She was living independently and she had a car, she used to go out, she was a very sociable lady. She travelled to Australia, she went to Mexico, she went to Belize, Guatemala, she played bowls, she worked on the canal as a volunteer. She was just a very busy lady, enjoyed socialising, enjoyed her grandchildren. She had a party in June with all her friends to celebrate her birthday. And then the fall happened in July, August time.
Falls will never go away, and we will never get the falls rate in hospital down to 0, but what we are striving to achieve is preventing the harm that occurs to patients.
The purpose is to try and reduce the falls with harm, so that's falls where patients end up with fractures as a result, or indeed some sort of head injury.
She was admitted to hospital, and then on the second night that she was in, we got a phone call. We just got home, we told that she'd just fallen out of bed and she'd broken her clavicle, and they thought her hip. My sister and I are both nurses, so we know the impact that that could have on her, but we thought, well, she'll have the surgery and then a bit of recuperation and then hopefully go back home.
Fall safe is really important because it helps us to keep our patients safe, it decreases workload for the staff, and it's a very simple, easy way of working. The 10 steps to fall safe we use in the Trust to help break down the elements of fall safe for the staff to be able to implement on an easy basis. So using either one at a time or a collective 2 or 3 to implement on their ward.
She had very bad post-op confusion and delirium, so she stayed in hospital for at least 4 weeks, and then it was decided that she wasn't perhaps safe to go home at that point, so we suggested perhaps a convalescence home for a couple of weeks just to give her a bit of time and then go back to her flat.
Every adult inpatient who comes into the AUH Trust, we would risk assess for falls, develop a specific care plan for that particular patient and look to see which equipment would be best suited for that individual. People don't always realise that a lot of what they do in terms of fall prevention is fall safe, and it is all included as part of fall safe. So simple things like giving patients core bells which are accessible at the beds, making sure that people have got safe footwear on their feet, whether that be their own footwear or whether it be the double-sided grip socks that we supply in the Trust now for patients.
Medication is very important in falls, and at least a quarter and possibly a half of all falls are due to medication. And this is one of 2 things, usually. Either the medications are causing sedation and the patient's balance is impaired as a result of having their senses dulled, or more commonly, it's causing orthostatic hypotension or postural hypotension, so their blood pressure drops when they stand up.
As soon as a patient is admitted to the ward, it's really important to do all the risk assessments because the likelihood of somebody being agitated, ill, wanting to get out of bed will happen very soon after they arrive. It's about putting patients in the right place too, so somewhere where they can be observed from the nurse's desk, or that there's a bay watch arrangement so that there's somebody in that bay.
I think the ways to overcome the issues with following the fall safe bundle is by educating the junior members of staff, to ensure that they are competent and confident to follow the fall safe bundle. So it's a clear structure, it's a clear guideline, it is evidence-based, so it guides you through to what you need to do to reduce the impact of that fall to that patient. Most of the patients who we get in acute hospital, especially in medicine, are having dementia or they're confused, and sometimes they forget to use the call bell, and if they need a toilet or if they need a glass of water, they tend to stand up, and if we don't adhere to fall safe bundle, they are going to fall and they're going to have harm from that fall.
Mum didn't ever go home after that. She went to the convalescence home, and she lasted one night there, and they called my sister. I was away on holiday. They called my sister and said that they couldn't cope. She was very muddled. She was walking around at night, so her confusion continued. She wasn't safe to go home. She then got more and more muddled. She was then assessed, and she was diagnosed with Alzheimer's from that. And yeah, we're now just over a year on, and we've sold her flat. She doesn't have a car anymore. She's in a care home. She won't go home now.
Implementing fall safe, it should be everybody's business. Everybody should be included. It doesn't matter who you are or where you are. If you see someone who's struggling down the corridor, you should be prepared to help them. If somebody's visiting your ward, you should be there to help them. If it's a patient or a colleague on your ward and an incident occurs, we should all be there to help them. The more eyes and ears we have looking for those potential at-risk patients, the better.
I think that this is a role for everyone who works on the ward, not just the doctors and the nurses, obviously the therapists, the OTs and the physios, but there's a great contribution from the domestic staff, the cleaning staff, the porters who come on and off the ward. Very often they'll be walking across the ward and there's a patient getting up in the corner, and their response shouldn't be to go and get the nurse, but actually to go and see that the patient's all right before they fall over.
As physios and OTs, we work with the patients at the time of the fracture or the time of the injury and right through until full recovery. Basically, we all have a role to play in prevention of falls in hospital. And if we're vigilant and we're aware and we take action, then we will all contribute to reducing the number of falls.
We need to prevent harm, and through doing these processes, which includes proper risk assessment in a timely way, implementing measures whereby patients are safeguarded from their falling or from any harm, really will make a difference to their stay, for them and their quality of care, and also for the staff in terms of managing them.
It's huge guilt that she's in a care home. You do question whether you're doing the right thing. She seems very settled, so I think that's all that we can hope now, is that she's settled. She still knows who we all are at the moment, so that's really nice. And yeah, that's probably the best we can hope for, is that she's relatively happy and settled. If you take anything, take on board the impact it can have on that individual and the rest of the family. It's so important to do those assessments on them, and if there are risks at all, then act on them. And it's very easy to do the risk assessment and perhaps we don't always follow it through. Just remember and put the patient first.
Does anybody have any questions?
Wow. Wow. That's huge.
I know.
I mean, that woman was doing everything, and all it was a fall in the hospital.
Independent.
Wow.
And we can really intervene
Yeah,
with
well,
falls
I've-
implementation of different interventions. And this false safety learning is going to be, how do we identify the high-risk patients? And then once we identify them, as far as implementing the processes in place. As I said previously, the nurse quality indicators are reported every time a fall happens. you report it immediately. And as far as like in the United States, it is in a database. All the reports are in a database, and that gives everyone, as far as anybody can look on Google and then see exactly what the statistics are. They might not want to come to your hospital. If you have a lot of falls, safety events, that's reportable.
And that's money. That's nursing staff.
Now, the process is implemented to decrease falls is performing a risk assessment on all patients. So you go into a room and you look around. You see if the water pitcher is in place. Is the call light at bedside where they can reach it? Do they have to get up and go around? Are they on medications that could cause them?
Is there a screen in the charting
Yes.
that'll help us, guide us?
Yes. It is falls safety screening, and there's questions that ask, is the patient confused? What medications are they on? And each one gives you a number, and if it's 13 or greater, then that is high-risk falls implemented.
Okay.
And it also gets nursing their, whether they think, they'll give a number from 0 to 10, 10 being the highest, and if it's greater than 13, then we're going to implement high-risk falls.
So let's say this person makes a 10. Can I, as a nurse, say, you know what, even though on the paper she makes a 10, I think she's a fall risk. Can I make her a fall risk anyway?
Yes,
Okay,
yes.
okay, thank you.
As far as identifying medications that are at risk, Ambien, just to name a few,
Anything that's a
Lasix,
sedative and.
any type of mind-altering, Xanax,
Gabapentin.
gabapentin.
Gabapentin's huge, yeah.
Rounding with a purpose. And every time that we round, and we round hourly, the aides round on the odd hours, nurses round on the even hours.
Yeah, we do that.
And go into a room, and you're not just like going by, looking and running. You're going in, assessing, ask the patient, do you need to go to the restroom? Can I assist you while I'm in here? Eyeball, see their cognitive status as you're looking at them, then see, okay, do they have their feet on, the skid socks on? Do they have the gait belt? And then just say, I got plenty of time to help you. What do you need?
Okay.
And then also make sure that the bed and chair alarms are hooked up properly if we use them. Now, we can also implement making contracts with patients that are alert and oriented and have issues with maybe gait or balance. Then we could say, just use the call light. The doctor wants to get a strict eyes and nose on you because you're on IV Lasix. So they really want us to measure. Is that okay if you will call out? And most times they'll agree, because I've made several contracts with patients. And of course, use of the bed and chair alarms, gait belts. And then another tactic and strategy is move confused patients closer to the nurse's station, where you can either visually or hear the bed alarm go off. Now, if the diagnosis is orthostatic hypotension, dizziness, syncope, do those blood pressures. Do it lying for 5 minutes, and then as you're standing, take the blood pressure 1 minute and wait 5 more minutes and take it standing again. And if there's a 20% drop in that blood pressure, systolic, or 10% on diastolic, they're positive for postural hypotension. Also, is the patient so disoriented that they're up and down all the time? Sometimes we have to order a sitter at the bedside. And we also have, just last week, they started at the hospital, Don't Walk on By learning module. And I know everyone hasn't done it yet, but it's going to go out to all staff. It's going out to housekeepers, physical therapists, occupational therapists, speech therapy, all our staff here in the hospital. And it talks about just don't walk by a room. If you see somebody that's getting up with the yellow slippers on, the yellow armband, the high-risk falls indicators, signage outside the door, then don't go in the room. Actually help the patient. Don't just go look for a nurse. And of course, you know, if we do have a fall, we have to report it immediately and do a post fall huddle on staff.
But we don't put that in the chart.
No, no. And then the medication review, I spoke about that. We also, as we give bedside shift reports, so the nurses as well as the nursing assistants go to each room. We're discussing the patient with them. And then we tell them at that point, is there any medication that this patient's on that could put them at high falls risk? And also there's a note that the nurses make on the patient's MAR. Now, purposeful rounding, I spoke about this earlier. Nursing assistants as well as nurses assess the cognitive status of the patient. You know, make sure the call light and the phone and the water pitcher or the urinal is by the bedside. And ask the patient if they need to go to the restroom. This is an example of how a bed and chair alarm are connected into the wall. And the blue tag is for the bed alarms and the red tag is for the chair alarms. And that is proper okay, this is a case study. And this actually happened. 72-year-old female admitted for congestive heart failure to our facility. Patient was alert and oriented, knew exactly, you know, her name, cognitive status. Well, she ended up falling. Somebody had spilled something on the floor and she fell and she had a subdural hematoma and she passed away.
Oh, wow.
And it wasn't my patient, but I actually saw that lady and the last thing, you know, she looked up and she said, I should have asked for help. The patient was in a semi-private room. She did say she knew she shouldn't have gotten up by herself. Her gait was steady. She had no obvious signs that she was a high falls risk, alert and oriented.
Other than being on Lasix IV,
Right.
which makes you go to the bathroom a lot, but.
Right. But the thing that was so significant to me was we appeared to be too busy for her. And she did not want to bother us.
But she was not on the high falls safety risk, right?
No.
Okay. It would have just been if we were rounding and stuff, we might have noticed there was something spilled on the floor too.
Right.
We could have stopped
Exactly.
that. Yeah.
Exactly. Here's another case study. 83-year-old male admitted for syncope, rule out stroke. You assess the patient, notice the patient's sleepy. Takes gabapentin and Lasix at home, states he's weak. What would you do under the circumstances?
B and C.
Choose B and C?
Mhm.
Yes. That is correct, because you want to make sure,
It's just because, I mean, he's already meeting the high falls risk, I would think, so.
yes,
Even without the form in front of me, I know that, so.
yeah,
Okay.
exactly. This one, a 22-year-old male admitted with alcohol abuse. C was score of 20. What would you do in this situation?
All of the above,
Yes,
even though he's 22.
right,
And we get them all the time.
exactly.
But
Yeah,
he's actually the one that's gonna fall out,
Yes.
just because you get him all the time.
right. Patient contracts, I've done this as well. I've said, please don't call out, please call out. The doctor wants, it's nothing personal. I'm sure you're alert and oriented, but just to keep you safe while in the hospital, I said, would you mind to call out for assistance? And most times they agree. It is an evidence-based practice, and nursing assistants can do that as well. It's in your scope of practice to go ahead and say, just call me when you want to get out. I will be happy to help you. Well, and then they'll say, no, you're too busy. No, I'm not. I'm here for you. And especially if you educate them on that, that makes them, bring them into the plan of care. That really,
Makes them active
they'll
participants.
follow,
Mhm.
right. So in summary, Falls will be tracked and evaluated per incident. For instance, I was assisting a patient. She was 42 to the restroom, and I had everything in place. I looked up at the heart monitor, and she was in VFib, and she passed out on me. Her AICD shocked her. She hit her head. There was nothing I could do. I was in the process of, grabbing her. There are some falls that cannot be helped because either the circumstances, but the things that we can do something about, that's why we're doing the interventions. Falls risk should be done every time we round. So every hour when you go into a patient's room, you're looking at that. Some people get sundowners at night. Just because you assess them at the beginning of the shift doesn't mean that they're not going to lose their cognitive abilities later in the shift. Or if they're going through alcohol or drug withdrawal, are they getting worse?
Even if when I was at lunch, somebody gave medicine that I didn't know about, they forgot to tell me, and it was Dilaudid or whatever, okay.
Yeah. But when you involve the patient in the plan of care, there are more positive outcomes. And they think, oh, okay, then I will call her. If she doesn't seem too busy, then I will call her. So we just have to be a part of that.
Somehow fake that.
We can make a difference in patients' lives. We can do so much. I'm very passionate about it because after witnessing that one incident, I just think, we can do more and more and add as much interventions. And the Shared Governance Committee also, any ideas you all have, please bring them to Shared Governance because we would definitely look at the evidence-based practice and maybe we can implement that. But I also have a post-survey for you to fill out and a test as well. Okay. And as far as the references, here are the references used.
Okay.
Does anyone have any questions?
No, I mean, I think we need more tools to do it, but you're right, if we could just convince the patient we're not too busy, that's half the battle probably.
Mm-hmm.
Okay. I don't know, can a patient refuse to be on a bed alarm?
Yes, they can refuse to be on a bed
I
alarm.
thought.
And you just document that into your charting. But what I do, if a nurse's aide comes to me and says they refuse to be on a bed alarm, I'll go in and ask them why. And if they refuse, still, even after me educating them about fall safety and practices why we do what we do, then it's their choice. And they're alert and oriented, that's fine. But you just have to at least talk to them. Don't just scoff off and say, oh, they're being non-compliant. Go in and talk to them and ask them, why are you refusing the bed alarm? Okay,
All right.
I want to thank you
Thank
for
you.
attending the presentation. And if you have any questions further down the road, please don't hesitate to let me know.
Thank you.
Thank you.